Now we know that the inner ear has two functions, function of hearing and function of balance. Now whenever there is any imbalance, that leads to vertigo. Yes, so whenever there is any patient who has come to us with vertigo, the vertigo can be not only because of the inner ear, it can also be because of other things like the three important things that manage our balance are the vestibular system, the ocular system, the proprioception, along with the center. The center coordinates everything. So if there is defect anywhere, it can lead to vertigo. So whenever there is any patient of vertigo that has come to us, we need to find out whether this is because of an inner ear pathology. And how do we find out? That we find out by the vestibular function test. So let us quickly see what are the important points that we need to know in the vestibular function test. So the vestibular function test that we need to know is, if the first thing before we go for a vestibular function test, the first thing that we need to do is take a proper history. If in the history there is history suggestive of ear involvement like hearing loss, like tinnitus, so all that tells us, or fullness in the ear, that tells us that it is an inner ear pathology. So you already have a hint that it is inner ear, right? If there is any involvement of nerve, if there is diplopia, if there is dysarthria, if there is very severe headache, all that indicates that it is a central pathology. Now, if there is no such history present which is suggestive either of a ear or of a central pathology, then what are the tests that we will do to find out that the disease, the pathology is in the inner ear? The first and the foremost is look for spontaneous nystagmus. So if there is nystagmus present, the type of nystagmus will immediately tell you whether it is a peripheral pathology or not. So what are the characteristics of a peripheral origin nystagmus? We know that the peripheral origin nystagmus always has a latency. Latency is present. Now you tell me the rest of the factors, whether they are present, not present. Yes, what it is. Duration. Peripheral nystagmus, will it be limited for a duration or will it be not limited? Yes, it will be limited. It will be limited for 1.5 minutes. Yes, 1.5 minutes maximum. Will there be fatigability present? What's the meaning of fatigability? Fatigability means repeatability is not there. Yes, so will it be present? Yes, fatigability is present. You do a particular test and you see nystagmus is present. You test again the vestibular system, again you see that nystagmus is not present. It was present last time, now it is not present immediately when you repeat. So fatigability is there. It means it is of peripheral origin, of vestibular origin, of inner ear origin. Now in the peripheral origin, that is inner ear origin, the nystagmus can be either a vertical nystagmus or a horizontal nystagmus, but always there is torsion. It is never pure vertical or pure horizontal. Pure vertical or pure horizontal suggests that it is of central origin. Now you will tell me that when will be stimulation of what will lead to, or involvement of what will lead to vertical, what will lead to a horizontal nystagmus in inner ear pathologies. Yes, so always whenever there is the vertical canals that are involved. Vertical canals. What are vertical canals? Vertical canals are the posterior semicircular canal and the anterior semicircular canal, that is a superior semicircular canal. Anterior is also known as superior. Superior is also known as anterior. Yes. So these are present in vertical orientation. So if there is any abnormality of the posterior or the superior semicircular canal, for example, if there is otolith which has gone there, so in vertical semicircular canal involvement, always the nystagmus will be vertical nystagmus. Is that clear? Whereas if there is horizontal semicircular canal involved, for example, if there is a BPPV, otolith has gone into the horizontal semicircular canal, then the nystagmus that you get is a horizontal nystagmus. If I ask you that in caloric test, I have told you about caloric test earlier also, and yes, you already know what is caloric test. We put different temperatures of water in the external auditory canal and we stimulate the inner ear. Can I ask you that what will be the type of nystagmus that you will get in this patient? Will it be a vertical nystagmus or a horizontal nystagmus? For that, you will first tell me which semicircular canal are you stimulating by doing the caloric test. Which semicircular canal can you stimulate by putting different temperatures of water in the external auditory canal? Which is the semicircular canal most accessible? On the medial wall of middle ear. So many hints I have given you. Yes, the lateral semicircular canal. Lateral is the horizontal semicircular canal. So what would be the type of nystagmus? Always a horizontal nystagmus. So always remember this. Yes. Now another important thing you need to remember is that if there is complete destruction of one side labyrinth, again the nystagmus will be a horizontal nystagmus. So horizontal nystagmus, vertical nystagmus with torsion. If you are getting, it indicates involvement of inner ear. Involvement of which part of inner ear? Vertical canals. Is that clear? Vertical with torsion you will get only when there is involvement of either superior or posterior semicircular canal. If you are getting a horizontal with torsion, that can be either because of involvement of horizontal semicircular canal, or that can be also when there is complete destruction of labyrinth of one side. For example, in labyrinthitis. For example, in vestibular neuritis. What's vestibular neuritis? Vestibular neuritis means that there is inflammation and destruction of vestibular nerve. So when the nerve is gone, it means that the whole of the labyrinth will not be, all the activity of the labyrinth will not be picked up. So it is complete dysfunction of one side labyrinth. So there the nystagmus will be horizontal but with torsion. Is that clear? Okay, clear. So now another factor important is optic fixation. Now you tell me optic fixation in peripheral origin nystagmus. Optic fixation. By optic fixation, when you fix the patient's eye, will this nystagmus of peripheral origin disappear? If it is of peripheral origin, will it disappear? Yes or no? Yes. Any nystagmus that takes time to appear, that disappears, that is fatigable, by optic fixation disappears, all that is peripheral. So yes, optic fixation, it disappears. It disappears. And very important is direction. Direction of nystagmus. If it is changing, sometimes towards the right, sometimes towards the left, then it is always of central origin. Whereas in peripheral origin, always the direction is fixed. Direction is fixed. It is fixed. And also what you need to know is what is direction. If I say that the nystagmus is towards the direction of nystagmus is towards the right. Even if I do not say direction of nystagmus is towards the right, if I say that nystagmus is towards the right, it automatically means that the direction of nystagmus is towards the right. So what is the meaning of direction? Nystagmus is like this, no? Fast, fast, slow. Yes, slow, fast, slow, fast. So what is the direction then? Direction is, can you make out? What are you able to make out very clearly? The slow or the fast? Slow or the fast? The fast. Yes, so direction of nystagmus is what you can very easily see, and that is a fast component. So direction of nystagmus is the direction of the fast component. Always remember, direction of nystagmus is direction of fast component. This is a repeated question that is asked. Okay, and what you need to know is that, again, yes, this is important. Don't ignore this. What you have to know is that if direction of nystagmus is the fast component, the direction of nystagmus can also help you to localize the lesion, which ear is involved. It can tell you that also. So in peripheral pathologies, the direction of nystagmus is always towards the more active side. Remember this, more active side. More active side means, suppose the patient has a normal ear and in the other ear, the right ear is normal and the left ear patient has a BPPV of any semicircular canal of the posterior or the horizontal semicircular canal. Yes, which becomes more active here. The BPPV, what happens there? Otolith goes into the semicircular canal, it excites it. It makes the semicircular canal hyper excitable. Yes, so here the more active will be this one. Yes, so you will get the fast component will be towards the more active side, that is towards the side that is involved. Is that clear? Whereas if it is a destructive lesion, for example, let us say that the right ear is normal and the left ear is vestibular neuritis, that is a destructive lesion. Neuritis. Okay, so in this case, what becomes more active? More active becomes this here. So then the direction of nystagmus will be this side. Now, why this is important? Last year was a question in your exam. This is a patient of vestibular neuritis with the horizontal nystagmus with torsion towards the right. Which side is a defective side? Yes, so we know vestibular neuritis is a destructive lesion and the nystagmus is always towards the more active side. So if in this patient there is a horizontal nystagmus towards the right, it means that right is the more active side. More active means it is the normal side. So the other ear, the left, is the destructive side. The left is the involved ear. So in this patient, the involved ear was a left ear. Is that very clear? Okay, so now in hyperexcitable lesion like BPPV, if there is a BPPV, then nystagmus will be towards the same side. Whereas in destructive lesion, nystagmus will be towards the opposite side. Why? Because that is the more active. Just remember, more active. If you know more active and you know what pathology that is, it will be very simple for you. For example, let us see this. If there is a posterior canal BPPV, tell me everything about the nystagmus of this patient. Tell me it will be vertical or it will be horizontal. It will be towards which side? Yes. So I am telling you that this is a right posterior canal, posterior semicircular canal BPPV. Yes. So tell me first, it will be a vertical or a horizontal nystagmus. Posterior canal is vertical. So it will be a vertical nystagmus. It will be vertical nystagmus. Second, tell me the direction of nystagmus. If it is of the right side, vertical canal, yes, BPPV is a hyperexcitable lesion. So that becomes the more active. So more active, that is the involved side. Yes. So the nystagmus will be towards the more active, or nystagmus will be towards the right side in this case. Suppose if there is a vestibular neuritis of the right side, vestibular neuritis of the right side, what will be the nystagmus, horizontal or vertical? You will get a horizontal nystagmus, and this will be towards the more active, that is towards the normal side. So if it is the right side that is involved, you will get the nystagmus towards the left side. In this case, you will get the nystagmus towards the left side. Is that clear how this nystagmus is important for us? Now, if in any patient we want to test the vestibular system, we can do it very easily in the OPD by doing a head impulse test. What is a head impulse test? We know what is the function of the vestibular system is that whenever there is head movement, so while moving my head, if I still want to fix my gaze on you, on any object, yes, so that is a function of the vestibular system. In response to head movements, it senses the head movements. The sensing of the head movement is by vestibular system. We know it senses the linear acceleration, rotational acceleration, angular acceleration, yes or no. So all this acceleration is sensed by the vestibular system. And then it immediately sends impulses to the eye for movement of the eye accordingly, so that our gaze is fixed on the object that we want. This is what is known as vestibular ocular reflex. So what we can do is we can give sudden impulses to the head, to the right, to the left, and we can see whether the patient is still able to fix his eyes on the given object. So if his vestibular system is normal, so on suddenly giving him head impulses, what will happen? Immediately the vestibular system will sense it. It will make the eye move according to the object that we want to fix our eyes on. Now, if the vestibular system is not normal, what will happen is this will be defective. Vestibular ocular reflex will be defective. And because of that, what will happen is that the eyes will move with the head, and then they will immediately try to come back to on the object which we want to gaze. So while coming back to the target, it makes fast movements, and they are known as saccades. So if the saccades are present, it means that the vestibular ocular reflex is defective. It means that the peripheral vestibular system is defective. There is a defect in the inner ear. So here, this is how we test the head impulse test. Now, when we have to do the head impulse test, what we do is we stimulate the labyrinth by sudden movements of the head. We know that the inner ear senses the head movements, the head acceleration. Now, if we, instead of giving head movements, we stimulate the labyrinth by different temperatures of water, and we see whether the labyrinth is responding normally or not, that is what is known as caloric test. So caloric test, what is this test? In this test, we put different temperatures of water in the external auditory canal. We stimulate the inner ear, and we see that by stimulating the inner ear is responding appropriately or not. So if I do the caloric test on me or on you, then if the inner ear is normal, then we will get a normal response. Yes, what is that normal response and how we test it, I will just tell you. And if I do a test in someone and if I do not get a response, means if I'm putting cold water and hot water in the external auditory canal, warm water in the external auditory canal, I'm not getting any response. It means that the labyrinth is hypofunctional. Is that clear? Many a times you ask me that caloric test can be done for normal also. Yes, what is that a test? It is a simple test like a head impulse test, in that the impulse that we are giving is sudden movement of the head impulses, sudden head impulses. So I can do the head impulse in you also, right? In me also. If I give sudden impulses to the head, what will happen? If my vestibulocular system is normal, my eyes will be able to fix on the target continuously. Yes, so I will know whether it is normal or not. Similarly, when I give different temperatures of water in the external auditory canal, I can test whether the labyrinth is responding appropriately, normally or not. If it is responding normally, it means that I have stimulated the labyrinth by a different impulse, and that is different temperatures of water, and the labyrinth is responding normally, means the labyrinth is normal. If it is not responding, it means that the labyrinth is hypofunctional. It can be dead, it can be hypofunctional. Is that clear? Have you understood that? Okay, now with that, let us see. So here, what the significance of caloric test is that we can test each ear separately. And what is the temperature that we use? The temperature that we use is plus minus 7 of the body temperature. So 37 plus minus 7, so that is 30 and 44. So 30 is called the cold and 44 is called the warm. And when we test, what is the position of the patient? The position of the patient is 30 degrees above. Why 30 degrees above horizontal? Because which is the semicircular canal that we are stimulating? The lateral semicircular canal, and the lateral semicircular canal is maximum responsive in this position. When we raise the head 30 degrees up, the lateral semicircular canal becomes vertical. So that is maximally responsive in the vertical position. That is why we are putting this position. So yes, the semicircular canal that is stimulated is lateral semicircular canal. The normal response is cows. What is cows? Normal. If your and my or patient's vestibular system is normal, if I put cold water, I should get a nystagmus, a horizontal nystagmus, right? Lateral semicircular canal is what we are stimulating. So lateral semicircular canal leads to what nystagmus? Horizontal nystagmus. So I should get a horizontal nystagmus towards the opposite side. Whereas if I am putting warm water, then I should get a horizontal nystagmus towards the same side. This is the normal response. If I get a good normal response, it means that the labyrinth is normal. If I get a hypofunctional response, how much is the duration, the latency, all that is measured in this test. And if I get a subnormal response or no response, it means that it is a hypofunctional labyrinth or a dead labyrinth. That particular year is the vestibular system is not functional at all. So this test of bithermal caloric test is what is known as Fitzgerald-Hallpike. Bithermal is Fitzgerald-Hallpike, right? And this is bithermal. We have another test which is known as COBRAC. COBRAC is the cold test, is the cold stimulation test. What is this cold stimulation test? Suppose I have not got any response in the patient when I did the caloric test. So I want to see whether the labyrinth is actually totally dead. Then what I do is I put ice cold water. I put ice cold water 5 ml, no response. 10 ml, no response. I increase it up to 40 ml. No in response, it means I declare that the labyrinth is dead. That is what is COBRAC test. It is a minimal cold stimulation test, just a cold stimulation test. Now this caloric test cannot be done if the tympanic membrane is perforated. So if the tympanic membrane is perforated, then what we use is a cold air caloric test. Air. In this we use a tube which is known as a Dundas Grant tube, and here we put ethyl chloride to cool the air inside, and then air is blown into the ear. So when the cold air goes into the ear, so this will test the cold test. So this is a cold test. We are not doing any warm test here. Now, whenever there is a patient who has come to us with a complaint of vertigo, on coughing, on sneezing, on pressure changes, on lifting heavy weights, on straining, all on Valsalva, all this indicates that whenever there are pressure changes in the inner ear, then the patient has vertigo. Normally, coughing, sneezing, they increase the pressure of middle ear, but do they lead to vertigo? Valsalva, that can increase the pressure of the middle ear as well as, yes. Does it lead to vertigo in us? No. So if pressure changes are leading to vertigo in any patient, then we need to rule out, is there any abnormal communication between the middle ear or inner ear, or is there any abnormal communication anywhere else in the inner ear which is leading to this pressure changes going excessively into the inner ear and stimulating it? Yes, so that is when we need to go for a test which is known as fistula test. What we do here is we increase the pressure of external auditory canal by the Seeger's speculum, and we see whether this patient is having vertigo or nystagmus and vertigo along with nystagmus or not. So here, if we do this test and we get vertigo as well as nystagmus while increasing the pressure with the help of a seagull's speculum, it means that there is a fistula. Where fistula? Fistula on the medial wall. Fistula on the medial wall. Where all can there be the fistula? Promontory cochlear fistula, fistula of the oval window, over the round window, over the lateral semicircular canal. Yes, so if there's a fistula anywhere, then the fistula test will be positive. So any fistula on the medial wall, fistula test will be positive. Right? Now also the fistula test can be positive when there is no fistula on the medial wall. So if there is no fistula on the medial wall, how then is this pressure changes, such small pressure changes going into the inner ear? Yes, so here, what are the causes when the fistula test is positive but there is no fistula on the medial wall? Pressure changes are leading to vertigo without a fistula on the medial wall. That is known as false positive fistula test or Henneberg sign. So yes, in mean ears, in hypermobile footplate of stapes. So what happens in these conditions is that in mean ears, what happens is we have the oval window here. Yes, the utricle and saccule are dilated, so they come very near to the footplate. So now when the footplate moves and pressure changes, it stimulates it. Yes, in footplate, hypermobile footplate, same thing happens. Hypermobile footplate, the footplate is very hypermobile and it stimulates the inner ear. Also in superior semicircular canal dehiscence syndrome. What happens in superior semicircular canal dehiscence syndrome is that there is a opening, a dehiscence in the roof of the superior semicircular canal. So now when the sound is going through the oval window, it creates abnormal movement. Normally through the oval window when the sound goes, it should go in this direction. Through the round window, it should go inside like this and out through the round window. So now this is the route that the sound usually follows or the vibrations usually follow. But if there is an abnormal communication here, there is abnormal movement of the perilymph because of the abnormal communication, because whenever there is pressure changes, whenever there is loud sound, all this will happen. So this abnormal movement of the perilymph, this will abnormally stimulate the semicircular canals leading to vertigo. So all this can lead to a positive fistula test without a fistula on the medial wall. That is what is known as Henneberg sign. Yes. Also it is possible that patient has a fistula on the medial wall, but the fistula test is negative. That is known as negative, but it is false. False negative fistula test. What are the causes? Can you tell me? Tell me, think and tell me. Yes, if the fistula is covered by cholesteatoma or the pressure is going into the inner ear but the inner ear is dead, not responsive. So false negative is in cholesteatoma covering the fistula or in dead labyrinth. In dead labyrinth. Now till now, whatever test that we were doing, whether it was nystagmus or giving head impulse and seeing, looking for saccades or giving the hot and cold water and looking for nystagmus, and all these tests, what we are testing is the vestibular ocular reflex, the nystagmus. Yes, the response of the eye in response to vestibular stimulation. So now we have another test which tests the vestibulospinal reflex. What is the vestibulospinal reflex? Yes, the function of the vestibular system is not only to fix the gaze, our gaze on the objects, but it is also to maintain our posture. So this is one test which tests the vestibulospinal reflex. From the vestibular system, what is the pathway of the vestibulospinal reflex? One of the very important pathways is that we have the utricle and saccule, right? We have the utricle and saccule. So from the saccule, through the inferior vestibular nerve, the impulses go to the sternocleidomastoid muscle of the same side after passing through the vestibular nuclei. Yes, so what is the pathway? From the saccule through the inferior vestibular nerve, it goes to the vestibular nuclei, and then through the vestibular spinal pathway, it goes to the ipsilateral sternocleidomastoid muscle. So from the inferior vestibular nerve, the impulses has gone through all this pathway to the sternocleidomastoid muscle, and ultimately what is the result? The result is the relaxation of the sternocleidomastoid muscle, relaxation of the sternocleidomastoid muscle. How is the relaxation? Relaxation occurs like this, yes, of the sternocleidomastoid muscle, relaxation. When does this get activated? When does this vestibulospinal reflex get activated? vestibular ocular reflex is active all the time. Now I'm moving my head, I'm looking at you, I'm walking, we are jogging, we are walking. Every time we get a clear picture of whatever we want to see. We do not get a hazy picture when a head moves, right? Yes, so all the time vestibular ocular reflex is active. The vestibular spinal reflex, this one that we are talking about, is active when? Yes, when? Have you noticed sometimes like this you do when there is a very loud sound? Yes, so this is in response to loud sound. In response to loud sound, you must be thinking, in response to loud sound, the saccule, the utricle and the saccule is getting stimulated? Yes, that happens normally, and we have been seeing that since childhood. Whenever we play, we say like that, dhappa, like that, yes, and the person gets scared like that. Whenever there is a bomb, if it was only the noise that was disturbing us, we would have just closed our ears like that. We do like this, yes. So in response to loud sound, what happens is, to maintain our posture, this is a reflex. So this happens, why? Because of the close proximity of the oval window with the utricle and saccule. The utricle and saccule get stimulated, not so much stimulated to lead to vertigo, but yes, that much stimulated to lead to this vestibular spinal reflex. So here, what is the significance of this test? If I do this test in you and me, we will get a normal reflex. So what is the normalcy is a particular range. That range we need not know. But yes, if we get a wave which has a latency this much, which has got amplitude this much, so that is supposed to be normal. Now, if we get a response which is less than normal, it means that that particular inner ear is not functioning, is hypofunctional. For example, if I ask you if there is vestibular neuritis of the right side, if there is acoustic neuroma of the right side, then this vestibulospinal reflex, this VEMP test, this is known as vestibular evoked myogenic potential. This is the myogenic potential, the potential of the muscle that we are measuring in response to vestibular stimulation, vestibular evoked myogenic potential. VEMP. Yes. So if there is such situation, vestibular neuritis, acoustic neuroma, where the labyrinth has become hypofunctional, then I will get a less than normal response. But if the response that I am getting is hyperfunctional, too much excessive stimulation, what does this indicate? It indicates that there is excessive stimulation of the inner ear because of what? It can be because of a fistula. It can be because of mean ears. It can be because of superior semicircular canal dehiscence, mean ears, because of the same reason, because of the utricle and saccule coming very near to the foot plate, so getting hyperexcitable. Or if there is any superior semicircular canal dehiscence, in all these cases, what happens? The inner ear becomes hyperexcitable. So in these patients, what will be the complaint that they would have come to us with? Yes, Tullio's phenomena. What is Tullio's phenomena? Vertigo and loud sounds. So these are the patients who would have come to us with a complaint that whenever there is a loud sound, then I get vertigo. Yes. So normally the loud sounds stimulate the utricle and saccule only that much to elicit this vestibular spinal reflex. Not so much that will lead to vertigo, but if it has become hyperexcitable, what will happen? The utricle and saccule have become hyperexcitable, and that is leading to vertigo now. So that is hyperactive response, means fistula, superior semicircular canal dehiscence, mean ears, hypermobile foot plate. So what we are seeing is that in these cases, in all these cases, we are getting a VEMP positive also, and also what we are getting is fistula test or a Henneberg sign. So those are the high yielding points that we need to know in the vestibular function test.